Good evening, class. We're going to talk for a few minutes tonight about chapter 12 in Dewara's text, and she jumps in chapter 12 to the hospital system. But um, before we get that far along with that, let's go back and maybe just review a couple of quick things about what we learned with socioeconomic impacts and a couple of things from some of the earlier chapters. And Dewara in her text says Pareto efficiency. It can't basically you can't improve the situation for everyone because of market externalities. It's and basically when markets fail, and we talked about this, the role of the government in market failure, it's typically driven by imperfect information. And on the government side of the house, Dewar makes uh, a comparison between public goods, which are non-rivalrous and non-excludable. And then she talks about public goods that are provided by the government. So they're not, what you might say naturally occurring public goods, but they're public goods that are provided by a government agency, could be federal, could be state, could be local, and they're generally financed or the money backing them is going to come from tax revenue, sales tax, income tax, property tax, some type of tax revenue. And then we um, talked about monopolies, we talked about perfect competition, talked about oligopoly. And in the oligopoly, there's kind of an interesting aspect where it talks about either tacit or kind of this overt kind of approach to setting prices in an oligopolistic market. Monopolists don't have to worry because they're the only game in town. They're the 800-pound gorilla. They're going to use marginal revenue and marginal cost to find the quantity and then read the price from the downward sloping demand curve. And in a perfect competition market, that downward sloping demand curve is horizontal or flat. And perfect competition producers in a perfect competition model are just going to accept the price that the market designates through supply and demand factors. Also, though, when you get into maybe a little in a monopolistic, competitive market, but more so maybe in a oligolistic market, you have things like branding, and you have information about advertising. And between information and branding and advertising, it tends to drive not only the prices that oligopolies can charge, but also the quantities that they're willing to produce. And the government role, while the government's sitting, up here looking at, watching monopolies, watching the oligopolies, government's role is to maximize public interest. Somewhat, they end up maximizing special groups' interest. And they want to provide efficiency. And they're looking at wealth, they're looking at services provided, they're looking at access. So the government's role in the healthcare market, just in general, is to really, they come across as they're trying to maximize the public interest. And I think that's going to pretty much take us up to any of the review that we wanted to do. And so we're going to jump into the history of the hospital system. And hospital system has been kind of a unique environment over the years. Quality, especially in the late 1800s, early 1900s. So, after the Civil War, after the Spanish-American War, quality might not have been the best that it could be. The Flexner Report came out in 1910. It condemned, and it was basically a condemnation of medical education. They were condemning the way physicians were educated. They were condemning the hospital systems. That Flexner Report in 1910 really drove the overhaul of the healthcare industry. And what you had was, surgeons versus physicians especially, again, after this, during the Civil War, after the Civil War, Spanish-American War. And when things hit the ground in World War One, or after individuals came back from service after World War One, and again, this Flexner report's driving this change. America started seeing a lot of change, just in general within the healthcare system, but specifically in the hospital system. Modern hospital transformation, start talking about germ theory of disease, causal factors, centralized medical care, especially advances in medical technology, and really significant advances not only in medical technology, but in the pharmaceutical industry. And you had surgical procedures, you had radical imaging, increased urbanization. You had physicians that were seeing one individual, and that started to expanding to providing healthcare services for an entire family. Patient expectations, caring environment, and a cure. They wanted a positive result. So patient expectations, in conjunction with research like the Flexner report and additional information, trying to break down the barriers of the asymmetric information that we've talked about on multiple occasions, really started driving significant changes in the way healthcare goods and services were provided to the consuming population. You had also changes in financing. You had financing, via taxation, via philanthropy, make consumer fees, kind of irrelevant. Consumers were taken care of, especially, in the early 1900s and even into the mid 1900s. The middle class utilization changed the fee schedule. So it was the middle class that started changing the fee schedule, or the demand requirements for healthcare goods and services of the middle class started driving fee schedules. Changes in physician and nurse responsibilities with credentialing and admitting privileges. There were just sweeping changes going on in the healthcare system, not only on the physician and nursing side of the house, but also on the hospital side of the house. From a hospital system, the development of private health insurance transformed healthcare financing. American Medical Association established the first Blue Cross plan, and it was Baylor's prepaid hospital plan, and it drove a monopoly in the healthcare industry. The Hill-Burton Act of 1946 brought government into the hospital picture, uncompensated healthcare, an expected element of the healthcare system. So you had the Hill-Burton Act. So if you go back through the history of the hospital system, you had a lot of these research proposals, documents, government policy that were driving changes in the healthcare system. The National Labor Relations Board in 1984 decreed that benefits, employer-provided health insurance, were part of negotiation. They were tax deductible and tax exempt. So from a employer standpoint, those were tax deductible. And things like polio vaccine, rubella vaccine, research tools, antibiotics altered consumer expectation and increased service demand. You started with the vaccination programs, antibiotic type of regimens that you were starting to see crop up. It started changing expectation and increased the demand for healthcare goods and services. Not only that, it increased the demand for healthcare insurance. Government purchasers, Medicare, Medicaid, provided a stable funding source. Providers, hospitals, physicians, early on in the process, it was difficult in some instances to have a paying public. There was even, my great-great-grandfather was a country physician, and a lot of his services were, paid for through a barter system. Uh, you know, Animals, fresh meat, vegetables. There was just a lot of barter system because there was not a lot of cash available for, especially physician services, to some extent, hospital services early on. So, increased physician incomes predicted, socialized medicine. The beginnings of investor-owned for-profit hospitals mitigated elderly and uninsured ability to pay. So at some point, you started seeing investor-owned, not only medical group, but hospitals starting to spring up. Remember, if you go back to Arrow's article that we talked about probably in the first week of class, his, many economists are, they still argue that it was a seminal article that helped change healthcare in the United States. Probably started working on it again in late 1950s. It was published in 1963, and lo and behold, in 1965, I think it was, Medicare and Medicaid voted in by Johnson. In 1966, CHAMPUS, the precursor to TRICARE for the Department of Defense for military individuals and their families and retirees and veterans, all voted into existence. And economists, first thing they do is they'll point to Arrow's article and say that was the driving force that started the revolutionary change of healthcare. Probably the driving force was back at that Flexner report. That was the initial driving force, but things were going along a little slower than they needed to be, and Arrow's articles probably pushed this forward. And then hospitals started intensity. They started trauma care. They started ICU. They started, NICUs. Medical interventions increased. And you started looking at, certificate of need. And you'll see that abbreviated in some of these journal articles as COD, C-O-D. DRGs moved hospital reimbursement from a retrospective to a prospective system using diagnosis and surgical procedure codes. And that's true for the majority of the lion's share of your hospitals in the United States, with the exception of cancer facilities, some children's hospitals, and some community hospitals. So those types of facilities, especially cancer and soul community hospitals, are still paid on some mechanism, maybe bill charge, maybe some kind of case rate, maybe per diem rates. But a lot of those type systems are exempt from the prospective payment system or the diagnosis-related grouping system that has taken the hospitals from a retrospective environment to a prospective environment. Also, you've got capitation, you've got risk sharing, you've got managed care organizations, you've got horizontal and vertical integration that is, again, significantly changing healthcare. And we started seeing a lot of this, started coming into effect in DRGs hit the system in, I think it was 1983, and then in the 90s and, 2000s, and even, and today. You've got payers and providers both struggling again over that financial coin that we talk about throughout this class, struggling over that financial coin. And the one thing I can, if I don't impart anything else to you in this class, is if you go into the healthcare environment and if you get into a situation, whether it's on the payer side or whether it's on the provider side, and you're asked to provide information, especially to senior leadership team, and the information you're being asked to provide doesn't quite make sense to you, what's the thing that I want to make sure you understand is always follow the money. If you follow the money, you'll understand. If you're on the health plan side or the payer side, you'll understand why providers are trying to negotiate in a specific way that they are. And if you're on the provider side, if you follow the money, you'll figure out quickly what the health plans are trying to do in that negotiation process. With that, we're going to stop on the first segment. And when we come back, we'll start talking specifically about the institutional setting. Talk to everybody in a few minutes.